Finally, I'm very pleased to welcome Dr. Alex Singer, who will be presenting on addressing disease risk factors in primary care settings. Dr. Singer is a practicing family physician, clinician teacher, and an associate professor in the Department of Family Medicine at the University of Manitoba, where he serves as the Director of Research and Quality Improvement. He is the Network Director for the Manitoba Primary Care Research Network, where he leads and collaborates on several regional and national practice-based research studies. Dr. Singer's research focus on using information technology in primary care settings. It's specifically in the areas of disease surveillance, virtual care, and pragmatic clinical trials based in primary care settings. He has published and presented on several topics, including quality improvement in primary care, chronic disease management, and resource stewardship in primary care. So thank you so much for joining us, Alex. I will pass the floor over to you.
Okay, hello. Nice to be with you guys again this evening for me. Well, evening for you guys too. And I've got half an hour, right, Linda?
Yeah, that's right.
Okay, so we'll
Thanks.
do a little bit of a whirlwind tour through a little bit of this area around social determinants, which I've done a few projects on, and I'll try to give you guys a bit of perspective of sort of what's happening in the primary care area of this space. And there's lots of things happening. Just briefly, you guys are mostly out west, but I'm out here in Manitoba and the Treaty 1 territory in the homeland of the Métis Nation. And we're privileged to occupy this land and share it with our Indigenous friends and colleagues. So, few conflicts of interest just to get across. I do have some grants, but none of them are going to affect what I'm going to talk about today. As I said, I'm going to try to make this a bit of a whirlwind so I can get through all the slides and then maybe have some time for questions too. So if I'm talking too fast, send me a message and I'll try to slow down. But this is basically what I would like to try to get through today, talking just a little bit about how important understanding and factoring in social determinants of health are, give you just a bit of a flavor for that briefly. We'll talk a little bit about practice-based research and learning networks and some of the work that I've participated in and sort of moving the needle on some of this. And then we'll talk a little bit about some of the current and future states. So risk factors for acute and chronic diseases are both social and environmental and relate to health behaviors, which shouldn't be much of a surprise to most people, but we sometimes think about healthcare and diseases as sort of being, purely biological. And if the pandemic taught us anything, it's that while the pandemic was caused by a virus and, COVID-19 is a virus, it unequally affected people based on where they lived and their social circumstances and, sometimes even some health behaviors, but things like cancer, heart disease, whole raft of other illnesses, relate to things like smoking and alcohol use, which broadly speaking are sort of the social determinants of health. And in practice-based and research in primary care, practice-based research and learning networks, there's been a whole bunch of work that's happened to try to understand how these things contribute to poor health. And certainly there was a lot of work during the pandemic that really shed some light. For those of us who had been doing this kind of work for many years, it was no surprise. Many people predicted very early on that there was going to be an unequal impact of this particular virus based on lots of different factors. And we saw that sort of play out through the years. So, this is one of the COVID-19 assessment centers that I think that's one of the ones from in Mississauga. And on the left is a map of Winnipeg that shows male and female life expectancy. And so you can see like an almost 10 to 15 year difference based on the neighborhood that you live in. And this map is repeated in multiple other cities. This is not unique to Winnipeg. There's a map like this for Vancouver and Toronto and most American cities where data is collected. And so you can see that huge disparity, between those who live in poorer versus wealthier neighborhoods. And when you look at this map, if you know anything about the city of Winnipeg, which you may or may not know, you can see that there's sort of that downtown core area, and as you go further away, the south end being a little wealthier than the north end. But as you reach into the suburbs where people tend to be a little bit more affluent, and houses, neighborhoods are a little bit different in terms of their age and all that kind of thing, you see life expectancy change. And so it's a whole series of factors, right? This sort of map based on neighborhood only gives you one snapshot of what's happening, but it just sort of lays it out bare. The map for New York is really fascinating because it sort of follows the subway tracks, but we'll leave the geography out of it because I love geography, but we'll leave it out for today. These are just two graphics from the CMA and an article that goes way back to 1991 that talks about sort of the concept of social determinants, sort of a framework to think about it in terms of sort of your things that you're born with and you can't really change, your age, your sex, some of those constitutional factors, your genetics, and then all the things that wrap around that, your sort of lifestyle, the social community networks, and then a whole raft of other things that actually impact your health as you go to sort of outside of that concentric circle. And the CMA put it a slightly different way, but you can see that there are certain things that you have some degree of control over, or not. I mean, you don't really have control over your biology, but many things that influence your health, like the environment and like your income and a whole bunch of other things that really you may have only limited control over, and healthcare and your biology actually make up sort of a minority of that impact to your health. So just worth reflecting on. And importantly, this is sort of a truism that is attributed to Peter Drucker, that if you can't measure it, you can't manage it. And Peter Drucker was a management consultant, a management thinker, but so the medical version of that is a famous quote that Don Berwick said, who was a former president of the Institute for Healthcare Improvement, which is that some is not a number and soon is not a time. So, and I had a Post-it note in my office for years that said hope is not a plan, because during a meeting someone said that they hoped things would go well, and I said that's not a plan. You can't do that. But the concept here is that if we don't understand and sort of get to a granular level thinking about social determinants, we'll never be able to sort of address them and reach at least with an aim to sort of having some degree of equity in our system. And so if we think about outcomes being unequally distributed, it means that we have to sort of measure things and try to apply resources where we can potentially do the most benefit. Now, of course, you guys are doing healthcare informatics, and so this probably is not terribly surprising to you, but this sort of concept of garbage in, garbage out, and garbage in, garbage out is something that I live with quite a bit in the world, the research that I do, which is mostly around using electronic medical records, and so there's lots of crappy and poor standards. The other sort of garbagey thing that can happen with health data is this concept of bias. And so this has gotten even more, so this article goes back to 2019, that this issue of bias has become even more of a challenge when you think about AI impacting sort of healthcare decisions and health data analytics. Because if you feed an AI system a biased sample or cohort, you're going to get answers that aren't necessarily true. And in many cases, depending on how the AI is developed, you're not going to be able to understand the provenance or untangle how it got to be that way. This example from 2019 was actually a situation where an algorithm was found to be racist and shared some racial bias. And the issue was that the algorithm was trained on a set of health data where the African American patients actually had less access to primary care and less access to sort of early intervention. So it appeared that they didn't need certain aspects of care, when in fact it's just that they weren't insured for those things. And so the case management was applied to sort of more complicated patients who invariably were white and had better coverage, sort of based on how some of the sort of the sort of economic data mapped in this case in this cohort to sort of the racial data. And so we have to be really careful as we apply more and more AI and natural or machine learning type algorithms to ensure that the data sets that we're using aren't in themselves inherently biased, or in this case, share a racial bias, but many types of bias can really influence healthcare. So just a word of caution as we move into sort of the big data age. For anyone who, you guys are doing Masters in Informatics, that's Larry Weed holding up a paper chart, and there are still lots of paper charts hanging around. If you ever have the opportunity to read some of Larry's writings, he's just phenomenal. And he said this many years ago, this quote, it goes back, and if we accept the limits of the discipline and form and keep the data in the medical record, the decision stats will be better defined. And my other favorite quote of Larry Weed's is coding is caring. He made these comments back in, I think this is part of that slide. Oh, sorry, there you go. Back in 1968. So just to say, one of the godfathers of medical informatics has been with us for many years, and is still influencing. He recently passed away, but is still influencing some of the thinking in terms of big data. And he was thinking about this before there were, supercomputers. Before people were carrying around supercomputers in their pockets. So there we go. So coming forward to sort of practice-based research and learning networks, this is just a couple of examples of. So I lead the Manitoba Primary Care Research Network, which is part of that one in the center, the Canadian Primary Care Sentinel Surveillance Network, and there's a group in Ontario that has formed to sort of coalesce another group of 6 practice-based research networks. So what these are is networks of practices, so groups of practices that agree to participate, and in this case share data and share it for the purposes of research and quality improvement. And so I'll share with you some of the work that I do. These are just 2 core concepts in terms of learning health systems, and sort of how practice-based research and learning networks sort of contribute to this idea of the patient's medical home or the patient's medical neighborhood, which is sort of a framework from the College of Family Physicians. But I won't spend too long harping on learning health systems, but suffice it to say, if we have any hope of getting out of our current challenges, particularly the crisis in access to primary care that we're sort of living through right now, we need to build agility and learning into our health delivery. So traditionally in Canada, sort of research and quality improvement were kind of done over, off to the side, and then health delivery was sort of, handled by, insurer, the province which provided insurance, and then, privately delivered essentially, or regionally operated hospitals, things like that. And the learning was often sort of disconnected. And there's lots of literature, the challenges of bringing, advanced research into practice. And so learning health systems are a way of really shortening the time and embedding the quality improvement and the research functions that are needed to change and iterate and improve our system. And so I'll leave it at that, but suffice to say, I think learning health systems really are essential. And if we're going to address the challenges that we have in the healthcare system, we can't just pretend that delivery is, off, is sort of over here, and the other aspects of understanding the system in the context of sort of research and improvement should be, disconnected from the delivery. The speaker who just spoke to you before, health workforce planning being done by HIE is a perfect example where, so the feds are handling health workforce planning, but actually feds don't hire a single or operate a single healthcare operation, right? The federal government funds healthcare and does this important work in terms of health resource planning and providing the information. But in fact, none of I don't work for the federal government. I don't even work for the provincial government. I actually work for a regional health authority. So we need to bring that research and that quality improvement right down and co-design things and bring them to the actual point of care, and build our systems to be both integrated, but also to have learning embedded. Okay, I'll stop harping on that, or I'll run out of time to talk to you about social determinants. So practice-based research and learning networks, I think, have a couple roles. One is sort of in helping to measure behavioral risk factors, because in Canada, we have this infrastructure of electronic medical record, and now being able to extract electronic medical record data. And then we also use surrogate measures. I'll show you a couple of examples where we use data that come from Stats Canada and others to really help us understand when we do studies of epidemiology or prevalence of chronic diseases, things like that. And then, of course, to contribute to learning health systems, so to tie in this learning to practices. So just a couple of examples. These are sort of more in terms of health behaviors around tobacco, alcohol, and substance use. So you'll see two papers, one that I was involved with and one that some of my colleagues did. So my colleagues did a paper looking at which patients get asked if they smoke and what's the percentage of that and what does that look like in Canadian primary care. And then a few years later, myself and a group of others repeated that. And we instead of looking at tobacco, we looked at alcohol consumption. And so, we know that alcohol consumption is an issue and it leads to a premature death. There was a whole big splash on the news not too long ago when they went and changed the guidelines around this. But a reasonable proportion of Canadian deaths are attributed to alcohol, both directly and indirectly, and it's associated with many major comorbidities. You can look at alcohol's sort of impact on your health of all the places that the alcohol touches, sort of starting in the mouth, and working its way down into the stomach and the liver, and then of course cardiovascular system. And so there's a whole series of things that alcohol does that leads to poor health. And so we looked at how many times people's family doctors or primary care providers asked them about how much they drink, and that happened about 40% of the time. Now, keep in mind, some of the patients in this cohort were under 18 or even younger. So, you wouldn't expect it to be 100%, but 40% was certainly lower than one would hope. But then we did see this sort of pattern, which is unsurprising, that it was much more common to be documented, certainly in males who have higher risk of alcohol misuse, but also people who came to see their family doctor a lot, and those who had some chronic comorbidities. So it seems that some patients are being asked fairly frequently, and that would sort of correspond with what we might expect in terms of who's seeing their doctors for care. But of course, when you go to pull this data and try to use it for research or quality improvement, you can see just a quick list of a few of the terms that get written in the chart, because most alcohol related information is recorded in free text. And so you get these kind of, acronyms like ETOH, which is an acronym that's commonly used. And then, drinks 5 units per day, FU/PD kind of thing, in various kind of terms. My favorite being hepatitis, because I'm locked inside me as still a 10-year-old boy. So the data cleaning that we did was this taking, and so this is an example from medication data where you take, a string of text and through sort of algorithms that are sort of trained, you can clean that text into sort of an actual medicine in this case, and then apply a code. And so we did that with the alcohol data. This is sort of a rough schematic of what we did in terms of the basic natural language processing that we applied, and how we did that for this paper on alcohol use. And we developed a reference standard that was basically cheap labor. So medical students looked at that list of crazy terms, the 1,000 ways that things that people write, we consolidated them, and then we trained these algorithms to be able to sort of validate. We trained and then validated them, so we tested them, and we used a few different approaches. One of them called the bag of words model, where you chunk a bunch of words together, and then the algorithm's eventually able to figure out that this cluster of words means something like a high or like a non-drinker or a light drinker or a moderate drinker or a heavy drinker. And so that way we were able to sort of pinpoint, okay, well, so 3% of the people in this cohort actually had sort of heavy or higher risk drinking versus moderate or lighter drinking. And then, 21% were not drinkers. And so that's what we did to sort of to create that algorithm. And we're actually doing this again, looking at substance use. This project I won't tell you too much about because it's kind of stalled. It was one of the many casualties of the pandemic. So I think when I presented this last year, I was very hopeful that soon we'd have it all wrapped up and I'd be able to show you a paper, but it's still underway. And actually, there's someone that just took it back onto their plate. So I hopefully will, by the next time I present next year, I'll hopefully have some actual data from the substance use. But we start, just to sort of show you how we do this kind of work, we start with sort of a cohort of patients that we have electronic medical records from in the network that I lead called MAPCRN, or the Manitoba Primary Care Research Network. We sort of whittle it down to patients who've had a visit in the last 2 years, or back in 2020 in the last 2 years. And then we sort of parse it out based on who has some documentation of, some substance use, those who do, those who don't. And we use those, dwindling cohorts to then try to train these algorithms. Lots of examples of where this has been done sort of in other places. So there's a whole other groups have looked at this for substance use and other sort of behavioral factors. And then, of course, in Canada, we've similar to the US in some contexts and in the UK, we have pretty good postal code data. So that comes from the Canadian Census, where you can combine you can take a postal code, a 6-digit postal code, and actually connect that to a neighborhood status. Now, it works really well in higher density areas because the postal codes are more frequent, and so down to sort of an apartment block often, or a small street. But then in rural areas, you can get a little bit of blurry sort of high variability. So you could have someone who lives in a very nice, well farmhouse that could be quite large, and they might have, although some people who are in the farming community don't make that much money, but that house could be right next door to the temporary foreign workers who are working in the farm. And so it doesn't always work quite as well in rural areas, but the postal code data works quite well for sort of attributing things like socioeconomic status, residential mobility, like a rental neighborhood versus lots of fixed family homes where people don't move that often, and all of these things can be factored in, and it's all based on census data. Eventually, there'll be integration, hopefully, into digital records, and I think there's some slides coming later about some of the work that HIE is doing. So this group actually, so for the first part, going back a step, doing automated detection, this group actually did a review in pediatric population of substance use data. I'm running out of time, so I will leave this slide, but I think you'll be able to have access to my slides. So just a quick snapshot of what they did. But this group essentially looked at building a natural language processing algorithms based on, very similar to the work that we had done here in Manitoba. And so this is the sort of a schematic of what they did. And then they built these rule-based natural language processing algorithms, and they actually mapped their algorithm to SNOMED, which I'm sure you'll learn more about if you haven't learned about SNOMED already. But it's an ontology of sort of medical terminology, and it's quite extensive. And so by doing this text processing, they were able to then map out some concepts and build out these sort of queries. This is what they found in terms of what they were able to derive out of the structured notes. And then you can see these interesting patterns of sort of certain things being much more commonly asked, like tobacco use and alcohol, which were very, very commonly, they were very commonly able to derive them almost 100% of the time. They were able to derive them from the notes, but less so with things like opiates, although still pretty high rates that the algorithm worked. And then this is sort of the performance of a different kind of model. So I won't go too far into that. This was a systematic review of extracting social determinants from health records. And so I'll let you read that on your own time. Interesting work, and just shows how many groups, there's a whole bunch of studies all around the world trying to use natural language processing to really try to derive these kind of things. And then I mentioned postal code data. So this is just a snapshot of a few studies that I've been involved with where we use social determinants of health indices. And so this one was pediatric hypertension screening. So it maps directly in pediatric hypertension. So if you look at pediatric hypertension, kids that lived in the most deprived neighborhoods actually had much. So the least deprived neighborhoods actually had much more screening. So they see the doctor more often, things like that. Yeah, but so when you have more screening, you have higher incidence. But I'll show you another interesting slide in just a minute on CKD. So we looked at the social deprivation index and the material deprivation index. These are both derived from StatsCan. The social one is a whole set of factors based on the neighborhood proportions of people who have some kind of family discord, and then people that live alone, and then residential mobility, which are all sort of surrogates of a more socially challenged neighborhood. And then the material one is more things like socioeconomic status, average income, graduation rates. So interestingly, not all of the deprivation indices had the same effect. So the material one in this case actually was the only one that had a statistical effect. And then when you flip that and you look at adult chronic kidney disease, So I like to sort of tease my nephrology colleagues that we do an excellent job in this country and other countries, in fairness, treating poverty with dialysis. And so you can see here from the graph that the rates of the prevalence per 1,000 people, so that's the rate of people with the chronic kidney disease, is almost not quite double, but 20% higher when you compare the most deprived neighborhoods to the least deprived neighborhoods. So rich people get chronic kidney disease at much lower rates than poorer folks. And so this is purely based on sort of what's considered deprivation, so socioeconomic status, basically. And so it's really interesting because we know this to be true, yet we spend huge amounts of dollars treating an end-stage disorder, which is at least 20% difference that are driven by living in poverty. We see the exact same pattern in things like post-traumatic stress, and I did some work around that. And you can see sort of urban and rural had an influence, and then of course this small impact between, but significant. Excuse me, it's not actually that small. And if you look at patients with PTSD, it's like a 40% difference, 30-something% difference between from the least deprived to the most deprived. So 6% versus almost 37%. So that's quite a difference when you're looking at something as impactful to people's lives. So, in the patients without PTSD, you can see it's a pretty balanced sample. And then when you scroll over one column over, from the least deprived to the most deprived, we had many more patients in our cohort, excuse me, who had PTSD. And so a variety of things play into that. And you can see sort of in this case, an odds ratio of nearly 4. For the social deprivation, but not as high for the material deprivation. So in this case, as opposed to CKD, the social deprivation seems to have a bigger impact, which is probably a chicken and the egg thing because folks with PTSD end up living in neighborhoods with higher residential mobility and more likely to live alone and a whole bunch of other things. So this one may actually be, it's not necessarily a causation, or it's actually the reverse. It's that the condition itself is causing some social deprivation potentially. So what can we do to address this? This is something that as providers, we spend some time. Certainly, it depends on your practice, but I spend a fair bit of time, although I'm lucky enough to have people like social workers and occupational therapists who work in my team. So I won't talk too much about the Get Your Benefits program. It's called the Poverty Tool in Ontario, and I don't know in BC what the program is called. But essentially, it's a guidebook, so sort of trying to connect people to resources to sort of address some people's social needs. And then, of course, on the sort of content side, HIE is right now, as we speak, going through a review of content standards. I was one of the people that about 15 years ago was screaming that we needed content standards, and lo and behold, finally we're doing this for EMRs. So now that everyone has an EMR, now we're making content standards. So it's a little late in the game, but so be it. So HIE is working on that. And I think Linda's talking to you a little bit later about this FHIR and LOINC and the implementation guide, which has existed for years. And so I would wish that just HIE would get on with it and actually just launch any standard. I don't actually think as long as it maps to FHIR or SNOMED or some existing ontology, that's probably good enough. But in Canada, we write really excellent reports. So we'll spend another few years working on this report, at which point it'll be that much harder to tie all the data to a content standard. But be that as it may, it's essential and it's important, and we need to get this done. So these are this is right from the HIE document. I'm probably not even allowed to share this with you. So I'll have to, I think I said that you could share these slides, but maybe we should take these ones out because I'm not sure if this is allowed to be reviewed. But anyhow, I'm trying to think anyways, no, maybe it's out for public review. So maybe I'm allowed. I should double check this before we share these slides. Anywho, so you can see they're all sort of in development. Things like language, education, relationship status, and at some point they've figured out they want to map race to some SNOMED codes. Although for anyone who has any kind of mixed parentage, this can get extraordinarily complicated. On the weekend, I was talking to it was at a friend's house, and there was a geneticist there who happens to be born in South Africa. I picked it up right away because I recognized her accent. But of course, her parents in South Africa, she would have been considered colored. But one of her parents had Dutch and Indian ancestry. Her other parent had Turkish and what was the other? It was Turkish and Malaysian ancestry, and of course she's African because she was born in South Africa. So I'm not sure she would have to tick all these boxes. But so there's a little bit of a folly here of trying to sort of identify these things specifically. Many people will tick many of these boxes, particularly in a multicultural country like Canada. But in Japan, this might be a little bit easier. But anywho, it is something that we're trying to get our heads around at least. And then, of course, indigeneity being particularly important in places like Manitoba and BC, where we have a large population of First Nations and Inuit Métis folks. So trying to understand some of those differences in terms of health outcomes. We know that Indigenous folks have poorer health outcomes for various reasons, lots of historical and socioeconomic ones. And then you can see sort of other ways of trying to classify things, gender identity and religion. And so hopefully with time, and if we actually apply these standards, there may be some way to try to triangulate and understand some of these intersections, but it's complicated. And you can see here some of the data elements for household income and access to food and things that are largely in development. And then there's folks this is from the Upstream Lab in Toronto, who put out some recommendations during the pandemic about collecting race-based data because it's so important and we knew it was impacting outcomes. And there's some good guidelines that the Spark group created to do that. And a couple of people I work with and I were involved in sort of Spark and trying to actually ask patients what they preferred to sort of how they identified themselves. And there's some guidelines that Spark is, I think they just got submitted for publication, sort of in terms of how best can you ask patients, what's the ideal way to sort of gain that comfort and who's the best person to ask and things like that. So because some of these things can obviously be sensitive. And so while screening for poverty and other social determinants is important, we have to approach it with some sensitivity when we're talking to patients, particularly especially in healthcare settings, because of course these can be loaded conversations. And in any healthcare interaction, of course, there's a power differential between the providers and the patients in many cases. And so we have to be careful about how we do this, but it is important, I think, that we do it. In one of the Spark studies we did, we actually used it with tablets, where the tablet was handed to people in the waiting room, and they actually answered the questions. And we did some focus groups to try to get the questions right, and some of that stuff's out there. And then, of course, within the Pan-Canadian Health Data Strategy, there's lots of emphasis on getting these data points into our health data because they are so important, and really, in some ways, the foundation of learning health systems to be at the population level to be able to understand things. So almost done. A couple more slides. Sorry, Linda. So this is just from the Pan-Canadian Strategy, which I'm sure you'll cover at some stage.
Sorry, did you mean to stop sharing your slides,
I did
Alex?
not.
Did you want to pick that up again?
Oh, it says I'm sharing.
I can see your slides, Alex.
Oh, okay, awesome.
Maybe change the screen. Sorry, Linda. I'm at the last slide here.
Okay, no worries.
Including
Thanks.
remarks. Yeah. So this one was just about sort of moving from the current state, which is really a paper-based system, sort of future state, which hopefully all of you will participate in as informatics leaders in the future, of having the patient, the flow of data actually follow the patient as opposed to be locked in medical offices and hospitals. And so this is what the Pan-Canadian Health Data Strategy sort of articulates. Super important work. And sort of in conclusion, we know that risk-taking behaviors and social material circumstances impact health. We know this to be true, and it needs to be measured constantly and repeatedly and in a longitudinal way so that we can try to address these kind of things. If we don't ask someone if they smoke or if they're having trouble paying their bills or affording food, it's very, very difficult to intervene. So in the same way that we would, as a family doctor, I would ask someone if they smoke and try to, encourage them not to smoke. I also often ask people, can they afford food, and can they afford the medicines that I'm prescribing them? Because if they can't do those things, then I also need to marshal some resources to ensure that, they have some basic things done So, work with our social worker, or I can, I can encourage people to file their taxes, for example, because believe it or not, if you file your taxes and you live below the poverty line, you typically get money. So if you make money and you file your taxes, you've got to pay. But for folks who live below the poverty line, actually filing your taxes gets you money. And many people don't file their taxes and therefore actually miss out on certain benefits. And in many places, like in Manitoba, you don't get pharmacare unless you have your tax return number. So these are sort of important, sort of basic things that don't often feel like healthcare activities, but in fact are, because we know it to be true that when patients actually have some higher income, they tend to actually do better. And some of the first studies to show that were actually done in Manitoba, and then it's unfortunately politically unpopular to have a basic minimum income, but that's probably one of the single greatest health interventions we could do. So last final pitch there. I also think that practice-based research learning and practice-based research and learning networks are a driver to sort of, stitch this kind of thing together into learning health systems. So I will leave it at that with that whirlwind tour of some of this fun and interesting data and work around social determinants. Open up for questions, and apologize to Linda for running only a little bit over time, because I think I started 7 or 8 minutes late. So
yeah, no worries at all.
There we
Thank
go.
you so much, Alex.
My
Always
pleasure.
entertaining. This is a really important topic, as you know, that's thankfully getting increasing attention in the world. So it's great to see. Does anyone have any questions?